Hello, and welcome to another Applied Radiology Expert Forum webinar. We're here to discuss the clinical benefits of perfusion MRI for glioblastomas. I'm Kieran Anderson, group publisher here at Applied Radiology, and I'll be your host and moderator for today's program, and I want to thank you for taking the time to join us. Today, I'm joined by a panel of experienced neuroradiologists who will provide insight into the effective implementation and management of contrast-enhanced perfusion MRI protocols and functional imaging techniques designed to improve visualization of the anatomy and physiology associated with glioblastomas. We've also included a review of a recently revised ACR guidance document designed to empower radiologists when performing perfusion MRI applications and hopefully will help them improve both their clinical confidence and their consultative role when communicating with patients and their care team. As you may know, glioblastomas are one of the most complex, deadly, and treatment-resistant cancers. They account for 50% of all primary malignant brain tumors, and it is estimated that over 10,000 individuals in the US will succumb to a glioblastoma each year. Now, despite these rather daunting facts, there is hope. As science is advancing rapidly, and there are promising research strategies moving forward. This includes the use of perfusion MRI in the diagnosis and management of this disease, which we'll hear about more in this special program today. So with that, let me take a moment to introduce our panel of experts who have kindly agreed to participate and share examples from their clinical experience when treating patients with this disease. I'll start with Dr. Leland Hu, who is an associate professor of radiology in the Department of Radiology at the Mayo Clinic. Dr. Hu, thank you for joining us and welcome to the panel.
Thank you very much, Kieran. Super excited to be here and looking forward to a great discussion.
Fantastic. Joining Dr. Hu, I'd like to welcome Dr. Gerald Boxerman, who is the Director of Neuroradiology at the Rhode Island Hospital and a Professor of Diagnostic Imaging at the Albert Medical School at Brown University. Dr. Boxerman, thank you as well for joining us today and welcome to the panel.
Thank you very much, Kieran, for the invitation. It's my pleasure to be here and to participate in this forum. I'm excited to participate.
Fantastic. And finally, let me now introduce Dr. Mark Shiroishi, an assistant professor and the director of neuro-oncology imaging at University of Southern California Brain Tumor Center. Dr. Shiroishi, thank you again for joining us today and welcome to the panel.
Thanks, Kieran, for the invitation and really excited to be on this panel.
Super. Today's program is accredited for educational credits for physicians, technologists, and radiology administrators. Let me point out that this program has been made possible through an unrestricted educational grant from Bayer Healthcare, and we would like to thank them for their support of educational programs like this. And now, in compliance with ACCMA policy, our faculty report the following disclosures, and I'll add that no individuals at the Institute for Advanced Medical Education or Anderson Publishing who had control over the planning or content of this activity have relationships with any commercial interests. At the completion of this activity, participants should be able to state the clinical benefits of MR perfusion and our functional imaging in the diagnosis of glioblastomas, be able to implement impactful MR perfusion imaging protocols in their practice, and finally, to be able to participate in patient and referring physician conversations in a more consultative role with improved knowledge and communication skills. So without further ado, I'll now turn it over to Dr. Gerald Boxerman, who will begin with an overview of the value of perfusion MRI and how the ACR, ASNR, SPR practice parameter for the performance of intracranial MRI perfusion imaging was developed and established. Dr. Boxerman will be followed by Dr. Leland Hu and Dr. Mark Shiroishi, who will add their clinical experience as it relates to the considerations and protocols for effectively performing perfusion MRI when managing patients with glioblastomas. Dr. Boxerman, the floor is yours.
Okay, thank you, Kieran. I think when discussing DSC MRI, it's helpful to remember that this technique mimics classical indicator dilution technique, which was a methodology developed by physiologists in the 1950s, where flow and volume of whole organ systems were determined from known quantities of an injected tracer, like a radioactive tracer or a visible dye, and measurement of the output concentration and residue function. And with DSC MRI, we try to apply this methodology to the brain to determine cerebral hemodynamics. So with DSC MRI, we use a gadolinium-based contrast agent as our tracer, and we image dynamically before, during, and after bolus contrast injection to yield signal versus time curves for each voxel. We process these signal versus time curves following the principles of tracer kinetics to make cerebral blood volume maps of the brain. Now, a small dose of contrast agent, which we call preload injection, can be injected prior to the bolus injection of contrast in an effort to reduce signal contamination from contrast leakage, since the tracer kinetic properties require intravascular tracer concentration. And so the protocol choices that we're faced with when we use DSC MRI include the preload dose, the contrast agent bolus dose, MRI acquisition parameters, including the flip angle, and post-processing techniques, including leakage correction software. Now, these protocol choices have historically varied quite considerably in practice. And this slide summarizes 3T DSC MRI protocol variation at 12 academic sites that participated in a DSC challenge that was organized by Laura Bell at Barrow. And you'll note on this slide that the flip angle and the preload dose varied considerably across these academic sites, with some variation in the bolus dose and the post-processing methodology as well. This variation is problematic in practice because it leads to very poor agreement measured by intra-class correlation for the computed cerebral blood volume across sites for the same simulated tumor using a digital reference object, with large limits of agreement on the Bland-Altman plot. So essentially what this study did was it simulated a single glioblastoma and applied that simulation to the acquisition parameters for all the sites that participated, and it came up with the cerebral blood volume maps that would have been generated for that tumor had the imaging been performed using those acquisition protocols. And there was quite large disagreement between those measures. And so it would seem that the protocol selection would matter because this could greatly impact interpretation of published results. So recently, a DSC standardization committee that was sponsored by the National Brain Tumor Society and other societies used previously published recommendations by the American Society of Functional Neuroradiology as a springboard for an updated consensus protocol that was recently published in Neuro-Oncology. To generate this recommendation, we used experimental data and computer modeling to derive a DSC protocol with high accuracy and precision. So our current consensus recommendations for single echo DSC acquisition parameters that are compliant with the widely accepted standardized brain tumor imaging protocol include a full dose bolus, low flip angle acquisition without the use of a preload contrast injection, and the use of modeling-based post-processing leakage correction. And by omitting the use of preload, we reduce gadolinium usage, and this protocol is very useful for routine clinical practice. Now, one can also use a full dose preload that would also permit simultaneous acquisition of dynamic contrast enhanced imaging, which we're not going to discuss in this forum, and this protocol may be useful in multi-center trials. So it might be helpful to go over what our workflow is at Rhode Island Hospital. We use the low flip angle acquisition without preload dose administration. We acquire 120 total time points that include baseline imaging. And we also simultaneously acquire both post-contrast imaging and FLAIR images that are co-located spatially to the perfusion images that permits for easy overlay when we do the image analysis. And all of our images are sent to PACS and our reading room MAC, where we process the CBV maps as needed, and all maps and overlays are sent back to PACS for access at subsequent tumor boards. Okay, with that said, I'll now turn the forum over to Leland, who will provide an anatomical review that could be helpful for interpreting the CBV images.
Thanks, Jerry. So we're just going to jump into actually looking at some images. And I think whenever we teach our trainees, medical students, and residents, we're always talking about understanding what's normal, a normal appearance of the brain, and that gives us a good gauge of what is abnormal in distinguishing the two. So this is actually a normal appearance of the brain. On the right here, we have a T2 weighted anatomic image, and on the left, we actually have a rCBV map, a relative cerebral blood volume map. You can see here that it's color-coded, but even though it's color-coded in appearance, it's actually quantitative in nature, because each of these voxels is actually associated with an actual rCBV value. And we can see here that this is a color lookup table to the lower left, and it shows basically the translation, so to speak, of color to actual values. And we'll see here that we have a number of arrows corresponding both on the anatomic images as well as on the rCBV map. So we can start off by looking at two of the white arrows, this one in the right frontal white matter and this one in the left occipital white matter. And we can see here that that's normal in appearance. It's T2 dark, which is consistent with normal white matter on a T2-weighted image. And we can see here that in general, the rCBV values are quite low. We can see here that they correspond with areas of blue and purple. And even though there's some heterogeneity, we generally record the measurements from a region of interest, or so-called ROI, and that averages across this area. And it provides a good baseline of what we consider to be normal appearing white matter, or you might see in the literature NAWM. And that basically just gives us an internal reference. And the reason why we need to do that is that even though DSC perfusion is supposed to be completely quantitative, it's actually what we call semi-quantitative, because there are some variations in measurements from patient to patient, and even within the same patient across different exams, because of differences in maybe the IV is not as good, or it might be a little bit different. The actual contrast dosage, we may administer a single dose, but maybe due to cardiac status, there may be some variability in terms of the amount of contrast that gets to the brain in terms of the rate of injection or what have you. And so we always use these normal appearing white matter regions as internal control. So each patient is basically, during that examination, serving as their sort of internal regulator, or internal reference, so to speak. So that's the whole reason why we're interested in looking at normal appearing white matter. There are some areas that you need to look out for that could have elevated rCBV that may mimic areas of tumor. And that's actually, here we can see this orange arrow showing what's a normal structure, which is the basal ganglia, specifically the putamen here. We can see, and here's the caudate head nucleus, and then it's separated by the anterior limb of the internal capsule and the posterior limb of the internal capsule. And inherently, gray matter actually has about 1.6 times the microvascular density as normal white matter. And so because of that, we'll actually see an increase in relative cerebral blood volume, because that's what is quantifying the microvascular density, or the microvascular area within tissue. And so because of that, the basal ganglia, or gray matter, is showing an inherently higher rCBV compared to normal appearing white matter. So you can see here on the color scale that it's going to be in the range of blue to green, and we can see that on the color map there. So it's important to know that some tumor values can actually get into the range of normal appearing gray matter, and so it's always important for us to understand the anatomic correlate, so to speak, when we're looking at just a perfusion map. We never want to look at a perfusion map on its own. We always need to correlate that with the anatomy. And then the final structure that's normal that I wanted to point out that could be, again, a tumor mimic is the actual cortex, or areas along the sulci. And the reason why these show elevated rCBV, you can see here that it's essentially white hot. It's off the scales because relative cerebral blood volume is really high in these areas. And the reason is that you have these cortical surface vessels. You have here within the sylvian fissure, you have the middle cerebral artery branches, the M2 branches, you have the leptomeningeal arteries, and you actually have cortical veins as well. And all those are super high in cerebral blood volume, and they're going to be very hot, so to speak, on the perfusion map. And so the reason why that's a problem is that sometimes these can obscure cortical lesions. And so when we see a lesion adjacent to the cortex, we have to make sure that we're not actually over-interpreting the relative cerebral blood volume because of the sort of bleed over, so to speak, from the large cortical vessels. And so that just gives us a general summary of the normal types of tissues and their perfusion characteristics on a relative cerebral blood volume map. So with that, I'll turn it over back to Jerry to talk more about examples of perfusion MRI.
Okay, so let me continue by starting to review some clinical applications of DSC perfusion MRI. Now that we have an understanding of the background and some anatomic considerations for how to interpret these CBV maps. One common application is the distinction of tumor from non-tumor etiologies for lesions. And let me start by showing an example of a case where DSC perfusion is helpful for such an application. So this is an example of a 78-year-old woman who presented with a clinical picture that was concerning for acute infarct. The patient had a non-contrast CT that showed some hypodensity in the right temporal lobe. And the conventional MRI images demonstrated a non-enhancing right anterior temporal lobe region of diffusion abnormality that had flare hyperintense signal, no evidence for contrast enhancement. And these features with the clinical presentation might be concerning for acute infarct, particularly given an additional focus of diffusion restriction in the posterior right temporal lobe. However, the perfusion imaging, the DSC CBV map, showed very high CBV corresponding to the region of signal abnormality, which is consistent with tumor. And in fact, this proved to be a high-grade astrocytoma. And so in general, the perfusion images, the CBV maps, might be a quick kind of binary way to determine tumor from non-tumor just by gleaning the presence or absence of highly elevated cerebral blood volume. And in this case, it was helpful for swaying us towards a tumor as the diagnosis. Now, we often encounter new lesions in the brain where both tumor and non-tumor etiologies are possible. Here is an example of two patients with similar appearing rim-enhancing lesions with mass effect in the brain. Now, tumors like CNS lymphoma in the top row have elevated cerebral blood volume, as shown here on the CBV map. You can see the rim of green, highly elevated CBV that corresponds to the region of contrast enhancement, whereas non-neoplastic processes like toxoplasmosis do not. And so here on the bottom row is a paucity of CBV elevation in the area corresponding to the rim enhancement on the post-contrast images. And these are often cases where, in my experience, one can often just eyeball the cerebral blood volume maps to determine the presence or absence of notable CBV elevation and generally arrive at some conclusion without the strict need for quantitation to make a determination as to whether we're dealing with a neoplastic or a non-neoplastic process. Now, quantitation can sometimes be helpful. We studied the cases in our case volume that were acquired with an older DSC protocol, and we found an optimal CBV threshold of approximately 1.5 for separating lymphoma from toxoplasmosis, for example. But clearly, the higher the CBV, the more confident one would be that the diagnosis is lymphoma and not an infectious or inflammatory etiology. Now, I think this is a case that Mark submitted for a review. So, Mark, maybe you want to chime in about another example of CBV application to tumor versus non-tumor etiology.
Yeah, thanks, Jerry. So this is a case of ours. There was a 55-year-old man who had presented with this rim-enhancing mass. And as you could see on the contrast-enhanced images on the left, you can see that the rim enhancement is quite thick and irregular looking, as opposed to what you might see with a more classical abscess, which would be much more well circumscribed and thin. And so there was a concern that this could be potentially a high-grade tumor. We did perfusion analysis on it, and as you can see, just by qualitative appearance of the color map, that the relative cerebral blood volume was quite low. On our software, we're able to get the mean value, and this is quite low, 1.1, using our acquisition parameters and post-processing leakage correction software and quantification, which I think we can perhaps talk about a little bit later. But anyway, the mean being about 1.1, which is quite low. And so this ended up being a strep intermedius brain abscess and not a GBM, although the conventional imaging was quite scary looking.
Okay, thank you, Mark. So again, this was an example where the quantitative value fell below this sort of mid 1.5 threshold, suggestive of a non-neoplastic etiology. And similar optimal thresholds have been published for tumor versus infection using different DSC acquisition protocols. Here's an older study that came up with an optimal threshold of 1.3. In principle, one might need to do analyses like these for each DSC protocol, since quantitative CBV values are protocol dependent. But in my experience, this 1.5 value seems to be a popular number and a fair rule of thumb. And I think we'll learn about similar thresholds for tumor versus non-tumor etiologies when considering treatment response of high-grade gliomas. Now, DSC can also help exclude tumor in solitary flare hyperintense white matter lesions such as this that enlarged over a short time interval. So here we see a young patient with an enlarging flare hyperintense white matter lesion that's grows quite substantially over about a 1 month time frame, develops some patchy areas of contrast enhancement. And due to the rapid growth and contrast enhancement development, there was some concern that this might represent aggressive progression associated with a tumor. But biopsy was withheld given that there was an absence of CBV elevation. And in fact, over time, the flare hyperintense white matter lesion shrunk in volume. The contrast enhancement went away, and this proved to be an example of tumefactive demyelination. So again, this is a case where the analysis of the perfusion CBV maps was sort of helpful for allaying some fear that we might be dealing with a high-grade tumor. Okay, so now we're going to turn to an example of how perfusion MRI can help distinguish a high-grade glioma from a metastasis. And here's an example, again, that was submitted by Mark. And Mark, you want to share your thoughts on this case?
Yeah, thanks, Jerry. So this is a 54-year-old man who had presented with this rim-enhancing mass. And I think at the time it was unclear whether he had a primary tumor or not. But nevertheless, he presented with this rim-enhancing mass in the left temporal lobe, and there's a moderate amount of edema around it. Now, looking at the rCBV color map on the right, you can see that just qualitatively that it's quite high, and quantifying the mean standardized relative cerebral blood volume is 3.5, which is quite high. And there is some preliminary data using our technique and our processing software that this is a lot higher than what we would typically see with metastasis. And so this ended up being a GBM rather than a solitary metastasis. So it can be helpful in these cases where you have a solitary lesion to make a differentiation between a primary high-grade tumor and a metastasis.
Okay, thank you, Mark. We now move to another application of DSC perfusion imaging, which is help with guiding biopsy and potentially grading brain tumors. So we're often confronted with cases where we see the presence of what looks like either a metastasis or a high-grade glioma, and the patient comes to biopsy, and the neurosurgeons are questioning what might be the most appropriate site to target for biopsy. And it's important to remember, as this case demonstrates, that high cerebral blood volume may be spatially distinct from contrast enhancement or flare hyperintensity, which are conventional imaging features to suggest the presence of tumor. So here in this case is an example where the yellow arrows in the first and second row point to elevated flare and contrast enhanced signal in different portions of this tumor. But these are spatially distinct from the areas of highest CBV elevation, which are noted to be more inferiorly within the lesion. And it's important to remember that contrast enhancement is a statement about blood-brain barrier permeability, whereas cerebral blood volume reflects microvascular density. And these are two distinct features of tumor physiology, and either contrast enhancement or CBV elevation can reflect higher grade components of tumor. And so it's helpful to interpret these in conjunction when determining an appropriate biopsy site. And our neurosurgeons routinely come down to the reading room to help for us to help them identify areas of high CBV that might be distinct spatially from other sites that might be suggestive of an appropriate biopsy site on the conventional imaging. CBV also generally increases with glioma grade, and one might think that you could look at the CBV value to determine whether it's a high versus a low grade glioma. And although this is generally true, there can be considerable overlap, particularly for the grade 3 versus the grade 4 tumors. So you can see here an example of 3 rows, 3 different patients with grade 2, grade 3, and grade 4 astrocytoma, with generally progressively increased values of the cerebral blood volume for these cases. I think that separation is much better when simply considering low versus high grade differentiation rather than trying to distinguish perhaps grade 3 from grade 4. But in general, there is progressively increased CBV with the higher grade gliomas. This can be helpful in some cases where you're not sure what whether you're dealing with a low or a high-grade glioma. So here's a case that illustrates how it can be helpful for predicting tumor grade. We see a well-circumscribed flare hyperintense medullary lesion that has minimal contrast enhancement, but it has well-defined margins and no surrounding edema, features which might be considered to be low grade at first interpretation. But the CBV map showed very strikingly high cerebral blood volume, suggestive of a higher grade tumor. And in fact, this lesion was found to be a WHO grade 4 glioma. So the CBV can sometimes be helpful for swaying your conclusion to be that of a high grade glioma, whereas the conventional imaging features might be suggestive otherwise. For gliomas, we often find CBV elevation preceding progressive contrast enhancing tumor. So here's a case of a non-enhancing right temporal lobe lesion, flare hyperintense lesion, no contrast enhancement, that progressively enlarges over time and was ultimately found to have a region of high cerebral blood volume without striking contrast enhancement, and this preceded by several months the development of contrast enhancement at that site. This was initially graded as a WHO2 lesion, but was subsequently regraded as a WHO3 lesion, suggesting either initial undergrading or high-grade transformation. And here's another example of a glioblastoma that had CBV elevation adjacent to the initially resected contrast-enhancing high CBV component of tumor. So here you can see at the pre-op scan, the rim-enhancing lesion, very high CBV, and adjacent to it is some subtle CBV elevation that has flare hyperintense signal and no striking contrast enhancement. But over time, after resection, we see the development and growth of contrast enhancement at the site of this CBV elevation. So this was a case where the CBV elevation was potentially helpful for identifying an early harbinger of disease progression. I think this is an example, and we might talk about this later on future directions, where some more sophisticated software might be helpful for better delineating these areas of subtle CBV elevation and separating it from the background of cortical CBV elevation that Leland talked about previously. Okay, so I'm now going to hand the platform over to Leland, who's going to talk about the use of perfusion MRI for a response assessment of high-grade gliomas.
So thank you, Jerry. Yeah, those are great cases, and we'll jump into response assessment with using perfusion MR. It's probably one of the most common indications for the use of perfusion imaging, just because of the non-specificity that tumor regrowth and non-tumoral post-treatment effect can have, because they can both actually present just in nearly identical fashion as a contrast-enhancing mass with surrounding edema. They can actually both progress over time in size and severity. And so it is a really common problem for us to try to differentiate, again, tumor growth, which represents a failure of treatment, versus post-treatment effect, which actually is a sign of treatment success and actually has a good prognosis. And the challenge is that a lot of times they can be histologically admixed even within the same lesion. And so that runs into some challenges. So we have seen throughout all these great cases that the reason why perfusion MRI is so helpful is that high-grade tumor, specifically high-grade gliomas, tend to have elevated relative cerebral blood volume. And again, non-tumoral processes usually have low relative cerebral blood volume. And so from a diagnostic standpoint, with the very cut and dry cases where rCBV is super high, there's no question it's going to be tumor. And if it's super low, then there's really little doubt that it's going to be something non-tumoral, like a post-treatment effect, like pseudoprogression. Here it's shortened, the acronym is PSP, or radiation necrosis, which we've shortened to be RN here. And they both basically represent similar types of post-treatment effect, PSP or pseudoprogression being a little bit early onset within, I think, 0 to 6 months or 3 to 6 months after chemoradiation. And radiation necrosis is usually more of a late stage post-treatment effect that we see greater than 6 months, sometimes as many as a couple years after initial treatment. But we all generally lump them in to the same category as being non-tumoral post-treatment effect. But in general, perfusion MR is helpful because it gives us quantitative values. Again, in real world situations where interpreting cases, it spits back a number for us. It could be 0.9 or 1.7 or 2.5. But it's important for us when we're actually trying to assign a diagnosis of tumor or post-treatment effect that we actually understand what constitutes a high value. What rCBV value can we use to assign a diagnosis of tumor? And, along those same lines, what constitutes a low value? How low is low enough that we can assign a diagnosis of post-treatment effect? And that's where some of these correlative studies become super important, because it provides upfront threshold values that are recommended to say, hey, if a lesion falls above this value, then we're fairly confident that it's this diagnosis and not that. And so that has really motivated a lot of correlative studies that you all might encounter in the literature that try to assign that threshold value. What is important to note, and really the whole motivation behind this slide, is that how you correlate those perfusion rCBV values with the gold standard, which is histopathology, is important to consider, because there is intratumoral heterogeneity or potential admixture of both entities that have, again, very opposing rCBV values, and that admixture can really degrade the confidence of your correlation. So this is a study that was published back in 2000, and it's just an example of what's called the non-localizing correlation method. So we see this large enhancing lesion in this yellow box on this T1 post-SCAD image, and usually a biopsy is taken from anywhere within this lesion. It's usually not documented, it's just randomly taken. And that one pathology sample gets diagnosed as either tumor or post-treatment effect. And that single diagnosis is then used to categorize this entire lesion as either one or the other. So let's say, for example, the biopsy comes back as tumor. So then the non-localizing correlation method, since we don't know where the biopsy came from, we tend to take a global average of the rCBV value. So this single lesion may be comprised of, let's say, hundreds of voxels. And so generally we'll just take the average of all those hundreds of voxels, and we'll come up with one rCBV value to summarize this entire lesion. Okay, so let's say that this particular lesion represents this top red lesion here. So it got diagnosed as tumor, and the rCBV value came back as 5. And so you go down the list and you recruit a bunch of patients and you sort of fill out this graph. Okay, so in the end, what we're looking at here is what rCBV threshold then can we reliably say, hey, if it's this value, then it's going to fall in the tumor category versus the post-treatment effect category. Well, the problem is that we see in this blue box that there's quite a bit of overlap between rCBV values when we hit the range of about 0.7 to maybe about 2.7. So if it falls within this range, then it's really a gray area. And the conclusions from this paper were basically to say that if it falls within this range, perfusion MRI is really not helpful. That sent a message to the clinical imaging community that, hey, maybe we shouldn't pursue perfusion MRI to differentiate tumor from post-treatment effect because of studies like this. Well, again, the challenge there is that the method of correlation using those non-localizing biopsies may not have been the best way to establish these criteria. So groups like ours have actually since then taken the approach of actually recording the location of each biopsy. So within a lesion, an enhancing lesion, we may actually take multiple biopsies from different regions. In each of those biopsies, and the beauty of neurosurgical navigation is that the neurosurgeons can actually document exactly where each biopsy location came from on the MR image. And so this is just an example where this biopsy was taken from central part of this enhancing lesion. The bullseye actually shows the stereotactic location and coordinates. We actually get stereotactic X, Y, and Z coordinates. And these can actually be used to then co-register to the corresponding DSC perfusion MR. So what we can do is we can say, okay, at this exact location, we got a diagnosis of tumor, or we got a diagnosis of post-treatment effect, and it allows for a more histologically pure isolation of a particular entity. And it gets around this issue of admixture. And then we don't have to average all the rCBV values over the entire lesion. We can actually be more precise in terms of spatial matching of the rCBV value that directly correlates with that biopsy location. So this is an example of stereotactic co-registration, where we fill out the number of samples and patients that we recruit, and we say, okay, let's say a lesion gets diagnosed as post-treatment effect. What's the rCBV value at that exact location? Okay, let's say that represents this dot here. It ends up being 0.8. And you just kind of fill in all of these and then look at the graph, and you can see here that the degree of overlap between tumor and post-treatment effect rCBV values is drastically decreased. And so this allows much more confidence in terms of providing a clinically confident rCBV threshold to differentiate tumor and post-treatment effect. And the key thing to take away here is that these thresholds can actually be applied at the regional level, even at the level of a single voxel, because of the way that we actually established these correlations and these thresholds, which was at the regional level. So what we can do then is take this to the voxel level and apply thresholds, and I'll get into that in just a little bit. But I do want to go back and say that the values that were published originally from our group were using normalized rCBV. And I sort of alluded to the selection of normal appearing white matter regions from using each patient as their internal control. And so I wanted to talk a little bit about what that process entails. When we select, sort of going back to the anatomy here, normal appearing white matter regions, it's important to note where that normal anatomy comes from. Here, one of the landmarks that we use is the frontal horn, where it is sort of shaped as the end of a hockey stick here, shown here in this insert. And we basically look at the frontal horn, the hockey stick, and we sort of extend to the end of it. Maybe this is a puck. You can kind of visualize it as that. And it's where this white matter is nice and plump. It's away from the sulcal vessels, so we're not going to get contamination from those large surface vessels. It's away from the ventricle, so we're not going to get contamination from CSF. And it's really a spot that we feel fairly confident of it being pure white matter. But we can also note that the anatomic location of white matter can actually vary the measured relative cerebral blood volume from those regions. There's even a regional variability within different areas of white matter. So we tend to try to select another normal appearing white matter region of interest on another slice in another part of the brain, just to give a more global representation of the normal white matter perfusion characteristics. And so because of that, we generally pick another area within the parietal white matter. So here we're actually a little bit more superior than with insert A. We're actually at the level of the corona radiata near the top of the lateral ventricles. And the way that we know that is the lateral ventricles, the lateral margin starts to take on this kind of straight appearance. This blue arrow here is actually showing a subependymal vein. And so we certainly want to stay away from those veins because, again, venous structures, arterial structures, they can have markedly elevated rCBV that may contaminate or may bias what we consider a normal control for that patient. So we want to stay away from that. So the reason why we generally select a normal appearing white matter region within this area is that you can see that the white matter is very plump and it's very far away from the ventricular margin, the subependymal veins. It's far away from the sulci and those large cortical vessels. So again, it's free from contamination or volume averaging. And I'm not showing it in this slide, but in general, if you pick this level and you go a slice up or a slice down, it's still going to stay within that white matter. So you're not getting this partial voluming effect off the slice. And so that's the reason why we choose these normal appearing white matter regions. Now, with that said, we found it to be quite reliable. And as long as users are trained, we have a number of technologists, med students, residents, and even attending physicians where we train up to try to select out these normal appearing white matter areas. With that said, even with an optimal amount of training, there is potentially some user variability in terms of, well, this person might select this area, but it might be off, or it might be different with another user. And so that user variability and dependence can, contribute to areas of variability in rCBV maps. And so that's one of the challenges of using normalized rCBV. So that's a reason why we actually have worked with Kathleen Schmainda and her group at Medical College of Wisconsin. They've actually developed a way of rCBV standardization where you basically generate equivalent rCBV values to normalized rCBV, but you take away that user dependence because you don't need to actually have a person select out areas of normal occurring white matter. And so they have actually replicated the study from our group, which used normalized rCBV, and they actually came up with very similar threshold values using standardized rCBV. And so you can use either one depending on your comfort level at your institution, but just to know that there are these two options of choosing normalized or standardized rCBV, and they're again fairly equivalent in terms of interpretation. So I mentioned before about the optimal threshold values that were determined from stereotactic co-registration. We can actually use those threshold values then to label each individual voxel as having a high probability of tumor or likely being post-treatment effect, depending on whether that rCBV value falls above or below that 1.0 threshold. And we've developed what's called the fractional tumor burden map, which is really essentially just a simplification of the perfusion map into areas that fall either above threshold or below threshold. And you can colorize them all different ways, but here we've chosen to colorize the voxels that have an rCBV above 1.0, normalized rCBV, is being red here. And it's really just a good way to visualize the spatial heterogeneity within an enhancing lesion, because each of these enhancing lesions, again, can be comprised of hundreds of voxels. And so by colorizing them, it really shows that, there is potential pronounced admixture, histologic mixing of areas of recurrent tumor and areas of post-treatment effect, shown here in red and white, respectively. And so it gives us, again, a good understanding that it's very difficult for us to potentially lump these large enhancing lesions as either one or the other. Meaning, would we call this, would we put it in the tumor category or would we put it in the post-treatment effect category? And that's really a question that probably needs to be addressed by the neuro-oncology community in the future. But at this point, it's probably safest for us to try to visualize and understand these lesions as being sort of a continuous variable, almost like a percentage, so to speak, of, hey, this lesion actually looks like it's maybe 50 to 60% tumor. And to label it as such, and in doing that, labeling it as a continuous variable of tumor burden, fractional tumor burden, so to speak, may potentially help us understand the prognostic implications down the road in terms of correlating with survival. And this is just an example of a fractional tumor burden map, or an FTB map, again, coming out of Kathleen Schmainda's group. Melissa Pra was the lead author here, basically using standardized rCBV. And again, they came up with standardized rCBV threshold right at about 1.0 that was fairly equivalent to our normalized rCBV. So again, you can use either types of rCBV values, and they can be used to create these FTB maps. Again, sort of a simplification based off of thresholding to visualize the heterogeneity. So our group then basically did a comparison study of normalized FTB and standardized FTB. And we found fairly equivalent clinical performance for either one, again, showing that you could go with either one depending on how it fits your clinical practice and your comfort level. And these are just some examples of FTB maps, again, sort of simplified thresholded overlays corresponding with biopsy locations from 3 different patients. And here it's just an example of where, and I should go back and say that these FTB maps are really colorized based off of thresholds of either post-treatment effect with rCBV below 1.0 And here we chose to separate tumor into rCBV between 1.0 and 1.75 or rCBV above 1.75. But just know that if it's red or yellow, it represents tumor. And if it's blue, then it represents post-treatment effect. And so we can see here that in both of these biopsy locations, we can see here that the biopsies were taken from areas of blue rCBV, meaning that it's a high probability of being post-treatment effect. And in fact, the biopsy, the neuropathologist reviewed all these cases and they found essentially no tumor was present. It was all post-treatment effect. Here is another biopsy location where we took a sample from the edge of an area of tumor shown here in yellow on the margin of a blue area of post-treatment effect. Histology found that there was an admixture, about 50-50 of the presence of tumor and admix post-treatment effect. And then this is another in patient 3, an area where we took a biopsy from an area with no blue at all. It was all either red or yellow. And again, it showed essentially all of the specimen or all of the biopsy contained tumor with essentially no post-treatment effect. So these are just kind of illustrations, again, confirming the visual mapping of the histologic heterogeneity and how it is congruent with the biopsy results. And so this is another case to illustrate this. This was actually a tumor board case that we encountered where the neurosurgeons actually took a couple different biopsies from the same enhancing lesion. And so here we see the post-GAD MRI shows this enhancing lesion concerning for tumor recurrence. Patient was taken to surgery and a biopsy specimen was obtained along the medial aspect during the course of surgical resection, but they submitted a biopsy specimen from the medial and anterior aspect of the enhancing lesion. We can see here that this circle, which corresponds with the biopsy location, falls within an area of higher rCBV on the color coded map. And we can also see that on the corresponding FTB map, it's predominantly in an area of red and yellow. And so this was highly concerning for an area of tumor recurrence. And in fact, biopsy from that specimen came back as recurrent GBM. Now, during that same surgery, the surgeons actually took another biopsy location from a more posteromedial aspect of the enhancing lesion. And we can see here that that particular biopsy location, number 2, corresponded with an area of lower rCBV, shown here and is bluish green. And the FTB map, if you again provide a simplified thresholded map, the color code actually looks predominantly blue here. And so this actually was suspicious preoperatively for an area of post-treatment effect. It was sampled and actually confirmed our suspicion that this was an area of non-tumor post-treatment effect. So again, just illustrating the fact that these lesions are spatially and histologically heterogeneous. They're oftentimes an admixture of both, and so it's really not necessarily appropriate for us to consider these lesions as one or the other. They're actually a variable admixture of both. Again, if we were to average the rCBV values across the entire lesion, again, that's not necessarily appropriate as well, that we need to start to consider rCBV values at the sub-regional level. Because if we were to, let's say, take a biopsy, let's say we use biopsy number 1 to confirm that this was, to label it as tumor, and then we took the global average of that enhancing lesion, it would give us an rCBV about 1.03. In contrast, if we were to use biopsy 2 as the results to label this lesion not as tumor but as post-treatment effect, and then we were to take the global average, this would yield an rCBV value of 1.05. Again, very close to those threshold values. These rCBV values are actually overlapping. They're essentially the same. And yet, if we were to use just a single biopsy to label these as one or the other, we can get drastically different results, depending on which biopsy we choose to be the gold standard, right? So this is, again, just illustrating why in previous studies using non-localizing correlation, you can get these results that seem way off. And then I wanted to conclude with a discussion. There's been recent debate and an effort to develop consensus recommendations for DSC perfusion. And really the debate, part of the discussion has really centered on whether we should be adopting DSC perfusion as routine, meaning every time a person comes in, especially in the post-treatment surveillance period, when they get a GAD brain, a routine conventional T1 post-GAD and T2 and T2 flare, should we or should we not be adding on a DSC perfusion during that time? And with what Jerry had discussed about recent consensus recommendations and development of a single dose, low flip angle consensus protocol, it really makes it very feasible, almost free, so to speak, to acquire a DSC perfusion during that administration of the single dose gadolinium-based contrast agent, because we're giving it anyways. We might as well take advantage of that contrast injection and acquire a DSC perfusion. And so there's been a number of papers, a growing amount of literature in support of the clinical benefits of using DSC perfusion and incorporating these maps in routine clinical practice. Again, recent consensus recommendations have gone out there and said, hey, maybe we should be incorporating DSC perfusion in routine response assessment after treatment of high-grade glioma. So this is just an illustrative example. I'll kind of end on this case where it's an example of the sort of status quo without implementing DSC perfusion as routine. Typically what we do is we get serial post-GAD MR. So this is a T1 post-GAD, or these are T1 post-GAD images. In this case, these were acquired at 27, 28, and 29 months. So 1 month intervals after chemo radiation or CRT. And what we see here is that over time, by the third month shown here, there has been development of this enhancing nodular component along the margin of the resection cavity concerning for recurrent tumor. So again, this patient, at least, on these slides, has undergone a third month of serial imaging. And so really the practice now would be to bring that patient back either at the fourth month or have them come back at least for a fourth visit to radiology and to get a confirmatory DSC perfusion. And in this case, DSC perfusion did in fact confirm the presence of recurrent GBM. This was taken to surgery and pathologically confirmed as well. But if we were to actually rewind and say, hey, we actually acquired DSC perfusion along with the post-GAD conventional imaging, we can actually, we would have actually had the confirmatory imaging test at the third month without the need to bring the patient back, and we would have been able to have provided a more confident diagnosis at the 29-month interval. But I'll actually go a step further and say that if we actually had serial DSC perfusion, we actually could have seen the development of the abnormal area of perfusion at month 28, a month actually before that preceded the development of the enhancement, similar to what Jerry had discussed before about non-enhancing tumor assessment. And so in this case, you could argue that the patient could have been certainly diagnosed appropriately at the third month, but even at the second serial time point, we could have raised suspicion and potentially diagnosed this and managed this patient at an earlier time point, even before the enhancement developed. So again, this is just illustrating the potential clinical value of incorporating routine DSC perfusion, especially in the assessment of these non-enhancing lesions along the margins of the resection cavity. And with that, I'll turn it over back to my colleagues for further discussion. Thank you.
Okay, thanks, Leland. I'm going to be going over some of the challenges that you can encounter when you're doing perfusion MRI, and with particular regard to artifacts and other technical issues that you can run into while doing it. So one of the major problems with perfusion MRI are artifacts related to things like the bone and air and things like that can really result in significant artifacts. So particularly lower down in the skull base is an example here. If you have an enhancing mass in the low temporal lobes, and you can see on the source images, you can see how much susceptibility artifact is here, and you can also see a lot of the air resulting in a lot of this dark signal here. And you can see if you look at the signal intensity time changes, you didn't really register any signal intensity time changes. So it's really important to take a look at the source images and kind of scroll through the images and see if the patient moved or if the patient's lesion is very low in the skull base. That can be particularly a problem. Here's another case. This is a case where a patient had a craniectomy, and the patient had a craniectomy, this mesh here to fill in the gap, and this is made of metal. And then this is a T2 weighted image. And then on the source images here, the gradient echo EPI source images, again, you see this very dark signal here that can make it very difficult to get an accurate measurement of your relative cerebral blood volume or any measurement at all. I think we have some examples of that. Here's just another example of a lesion that was low in the skull base. And if you look at the perfusion source images, again, you already see this low signaling here because you are trying to check signal intensity time changes over time. If it's already contaminated with this very dark signal, it may be very difficult to pick up a signal there. Motion is also another big issue that you can encounter because you are imaging a patient dynamically throughout time, and you want to really map the signal changes over time in every voxel. If the patient keeps moving, then you're no longer really mapping that same area in the brain because the patient's moving. Depending on what kind of software you have, there may be a way to get an idea of how whether there was a lot of motion or not. On our particular software here, you have these graphs that are available that can give you an idea of if there was motion. This orange is a QA graph that can give you the average signal intensity of all the voxels. And generally, you want to see a signal drop, and you want to see this relatively flat. And you can see this orange graph is moving all over the place. This red and blue gives you an idea of the bolus injection. And you can see that while an injection was given around the 60-second time mark, you can see throughout the post-bolus time that there was a lot of jaggedy spikes here that can be really concerning and can lead you to suggest that there was either a problem with bolus or probably motion artifact. And so even though you are able to get these maps to be to really question whether or not you can rely on those images or not. And I find that that is really common with any kind of automated software for people to just jump to the maps and just kind of record what the maps say without really checking to see first whether or not you should even use the images because of these issues related to artifacts and also motion. Here's a better example here of what ideally this should look like. So in our particular software, you see this nice orange QA graph showing the signal intensity is fairly even, and it drops during the first pass of the contrast agent going down. And as you see, it's fairly smooth. And again, you can see these curves showing the bolus injection. You see this the spike going in, and you can see it's relatively even as opposed to what you saw on the previous, where you saw those tremendous jagged spikes. And this is the fractional tumor burden map in this particular case. But it again, emphasizing the need to take a look at these quality assurance maps and not just look at the resulting parametric map that you get from that. Here's another case where here's the rCBV color image, and then you see the source images, and again you don't see any change in the signal intensity. So something went wrong with the bolus, and you didn't really record a contrast bolus going into the brain. Another example here of a large enhancing mass in the right temporal lobe, and then this is after surgery, and you see some residual contrast enhancement, maybe some blood product in there. But then you see on the standard T2 star weighted gradient called echo images, you can see this blooming artifact, probably from blood products, and then you see here lower down susceptibility artifact here, probably from the paranasal sinuses. This is the DSC source images. Again, it's very similar sequence, and you see the dark blooming signal here in the area, the resection, as well as in the low frontal areas. And then if you process it and you get this, you can have these cases where you just get signal dropout and you don't really get any, it's just black and you don't really get any measurable signal here. And this is from this severe susceptibility artifact. And so that's another thing to consider. Take a look at your images on your conventional scans, in particular, look at the gradient echo T2 star weighted images as well as source images, and see if it's really, really dark like this. And you might want to reconsider whether or not you want to process it or not. And then if you do process it and you see these just black holes here where you literally don't get any measurement of rCBV, then you know that you can't really use that. I think that's it. I'll turn it back to Kieran for further discussion. Thanks.
Well, gentlemen, that was a really, really great discussion. I want to thank you all for taking the time to prepare all of your cases and slides. Thank you for sharing all of that with us in the audience. We've got some time, not a lot, for a couple of questions that have come in from the audience, so we're just going to get right into it. I'm going to start with you, Dr. Shiroishi. What would you say are sort of the primary considerations for either starting a perfusion MRI program and also like who should be involved outside of course, the radiologist? So maybe you can just give us a quick little, some thoughts there.
I think just from a technical standpoint, making sure that your technologists are acquainted with the protocol and how to perform the perfusion, making sure that they have a large bore IV in the antecubital fossa, preferably the same technique in the same arm, and being comfortable with using a power injector, and assuming that most of the GRE-PI sequences are standard on all modern scanners, and so that shouldn't be an impediment. And making sure that you have the the parameters and using the consensus recommendations that were outlined here of how to set up the sequence is fairly straightforward. And then from an implementation standpoint, ensuring that your referring clinicians understand the uses and the way to interpret perfusion MRI, and maybe having a grand rounds or something and talking to the clinicians, the oncologists, the radiation oncologists, surgeons, and making them understand what perfusion can potentially give them, I think would be a really great way to start. And also understanding your software and making sure that you have adequate technical support or have someone to ask, because each software can be quite idiosyncratic, and understanding the bugs or troubleshoot when you have issues with that, I think it would be really helpful.
Thank you for that, Dr. Shiroishi. We've got another question here. It looks like it's about training and resources, what might be needed or required. Dr. Boxerman, would you maybe address this one?
Yeah, I think sort of echoing some of the comments that Mark made, I think that it's particularly helpful given that we use this technique for assessing response assessment to high-grade tumors. The results of the CBV processing are commonly shown in a tumor board setting. And I found from personal experience that it took a little bit of time to educate the neuro-oncologists, neurosurgeons, radiation oncologists about the value of this technique. This came about by showing the maps and discussing the implications of the findings at tumor boards. But once they got on board and became facile in what the maps represent and how to interpret them, they became very enthusiastic believers, if you will, in the methodology. And in fact, I found that in some cases, if we neglect to include the maps in a tumor board setting, they'll actually ask for it, or they'll ask for the patient to come back if perfusion imaging was not performed. So I think that with the proper education and providing the appropriate background, the clinical colleagues can come on board and and welcome the methodology as an integral part of the patient's evaluation.
Wonderful. Thank you for sharing that, Dr. Boxerman. We have another question here about impediments to sort of routine clinical use of perfusion MRI, and if so, how can these be addressed? Maybe Dr. Hu, could you take this one?
Yeah, sure. Yeah, in terms of the clinical impediments, really what Dr. Shiroishi had kind of brought up about making sure that you're set up for the correct acquisition. All you need really is a power injector, just awareness of, again, putting the large bore IV. And so in terms of acquisition, those are the things that you have to address. And then what Dr. Boxerman had alluded to, you just need awareness for the referring clinicians to actually order it. And really, once they start to see the clinical benefit, once the reading physicians get to see how useful it is, I think it'll start to take off, because you can't interpret perfusion without having it ordered and acquired. But I think those are the main points. And then, again, kind of going back to the consensus recommendations presented by Dr. Boxerman and alluded to by Dr. Shiroishi, that's important as well, to make sure that you get the acquisition protocol correct, because that's really a key piece to accurate interpretation once the images are acquired.
Thank you for addressing that, Dr. Hu. Another question popped in here, pretty basic one, probably a quick answer. Is perfusion MRI safe? Maybe you, Dr. Boxerman, could you take that?
Sure. So I think it's important to remember that perfusion MRI, DSC MRI, uses the same contrast injection that we administer for conventional post-contrast imaging. So the consensus protocol was set up to ensure that the same amount of contrast is used for both. So really, when you're talking about adding perfusion MRI, DSC MRI to your protocol, it really doesn't require any additional contrast injection unless you want to go with the full dose preload approach, which, as I mentioned, may have some limited advantage if you're considering the simultaneous acquisition of DCE MRI. But for most purposes, our recommendation is to use this low flip angle, no preload approach. Doesn't require any extra contrast administration. Imaging time is only increased by a few minutes that it takes to acquire the dynamic imaging. So there's really not much extra resources or imposition to the patient. So I guess the short answer is that it really is safe and doesn't incur any additional cost.
Thank you for addressing that, Dr. Boxerman. And this will be our final question. I know we didn't get to all the questions that have come in today. We will do our best to respond to them separately. Doctors, what does the future hold for the use of perfusion MRI? So, like, put on your crystal balls. What's on the horizon in your eyes? I'll start with you. Just 1, 2, 3. Dr. Shiroishi, your thoughts.
I think one big issue, I think we've focused primarily on glioblastoma and high-grade gliomas. One other major area is the evaluation of metastasis after post-treatment and really understanding what are the thresholds for those. That's been kind of underexplored, and that's way more common. And so I think that would be something that we really need to kind of figure out what are the values for that.
Dr. Boxerman, your thoughts.
Yeah, the ultimate goal here is to improve and impact patient care. And the main criteria that's currently used clinically, for instance, for a response assessment in high-grade gliomas is the RANO criteria. And I'd like to see ultimately DSC MRI mature enough to be accepted and incorporated into RANO. That would be really the ultimate testament of its accepted clinical utility. I think that improved software for identifying these subtle areas of perfusion elevation that are separate from contrast enhancement that might be a harbinger for disease progression might help us capture early progression a little bit sooner than we do currently. So I think software development is another tool that will be helpful down the road. I think these are some of the two of the main areas that I see of improvement that we'll hopefully realize sooner rather than later.
Thank you for your thoughts there, Dr. Boxerman. You get the final say there, Dr. Hu. Your thoughts on the future of perfusion MRI?
Sure. No, I agree with Doctors Shiroishi and Boxerman. And one thing that I might add is just, it's great at assessing non-enhancing invasive tumor. And it doesn't have to be in the post-treatment setting. It can actually be upfront. We know that a lot of these high-grade gliomas and GBMs are incredibly invasive. The contrast enhancement itself only captures a subsegment of that with blood-brain barrier disruption. In addition to rCBV, I think there are a number of other metrics that we didn't get into here, but PSR, K2, leakage transfer constants that are potentially useful in giving good biological information. With the consensus protocol, I think hopefully we'll start to see more adoption. We'll be able to have kind of the broader community provide input and data backing the science on its clinical utility. And, I think the future is bright.
Well, doctors, that was a really, really great discussion on how the effective use of perfusion MRI can make a significant difference in managing patients with these glioblastomas. I want to thank you all on behalf of the folks at the Institute for Advanced Medical Education, of course, my team here at Applied Radiology, for your time today. Thank you again, gentlemen. Let me also take a moment to thank Bayer Healthcare for supporting this educational program through an unrestricted educational grant. Their support of programs like this is greatly appreciated and has a significant impact in helping us bring educational programs like this to you. And finally, let me thank each of you in our audience who took the time to join us here for this program and for your continued support of applied radiology in general and the programs we deliver. We hope that you found today's program of clinical value to you and your practice, and that we'll see you online again for another Applied Radiology Expert Forum program. With that, today's program has concluded.